Good afternoon. Welcome to our Let's Talk Parkinson's event, brought to you by Parkinson's Community Los Angeles. Today we're learning about gastroparesis and Parkinson's disease and how to treat it. My name is Mike Wyman. I serve on the PCLA Board of Directors. For those of you who don't know us, we're a Los Angeles-based nonprofit that provides support, resources, and community for families living with Parkinson's. I'd like to thank our sponsors for Let's Talk Parkinson's series, Abbott, AbbVie, Boston Scientific, and Medtronic. Free programs like this are also made possible by donations from the community. If you appreciate free programs like this one, please consider making a donation on our website at www.pcla.org. A few more notes before we get started. We're recording today's event for our YouTube channel. Your video image will not be visible in the recording unless you are speaking. We'll send you a link to the recording when it has been posted to our YouTube channel. Please stay muted during the event to keep background noise at a minimum. If you have any questions or comments, you can type them in the chat at any time. Please keep your questions on topic. I know we'll have a lot of questions today, and we will do our best to get to as many of them as possible. We're joined today by Dr. Wael El Nashef. Dr. El Nashef specializes in gastrointestinal manifestations of Parkinson's disease. He completed his clinical fellowship at UCLA before performing his PhD work at Caltech. Dr. El Nashef's clinical interests include gastrointestinal complications of neurodegenerative disorders such as Parkinson's disease and esophageal and gastrointestinal motility disorders. Thank you, Dr. El Nashef, for joining us today.
And thank you very much for giving me the opportunity to talk on this topic. It's always a great honor to speak with you all. We're focusing today on gastroparesis and Parkinson's disease. I believe it is Gastroparesis Awareness Month, so it's a very topical subject matter. Here's a roadmap of what I hope to discuss. And I'm going to start off with something a little bit unusual, but just to sort of frame the topic a little bit. And then we'll just go over the usual things like, what are the signs and symptoms of gastroparesis? How does the stomach work? What's the matter? What's wrong with the stomach in gastroparesis? How do we diagnose this problem? How do we treat it? And then, gastroparesis isn't only found in Parkinson's patients. You can see it, actually, most cases are not coincident with Parkinson's. It's people with diabetes or viral infections and other things. But in the Parkinson's population, there's very special topics and issues we need to be aware of. And we'll go over that. And I'm going to try to leave a lot of time for questions. I'm sure that there is, a lot of questions on your end. So I just want to warn you, this is just a made up example. This is not a real thing. I'm just trying to illustrate a point here. And so let's say there's a condition, and we're going to name it bipedal ambulopathy. And it's an increasingly prevalent problem in society. The symptoms are that patients are unable to walk very far distances. And when we do objective studies, we find that people with BPA, because it's an acronym, it wouldn't be a real disease if it wasn't an acronym, on average walk 50% less distance on a treadmill compared to people who don't have BPA. And then the treatment, they did some studies and they saw that some people with BPA got better with ibuprofen. And then within that population, some responded to knee replacement surgery. But we don't really quite understand how it works, right? So what I'm trying to focus on here is that medicine has its own language, and sometimes we hide behind it. And we give names to things using technical language that can kind of make it obscure to non-physicians. And honestly, it makes it obscure to the physicians themselves too. We kind of get lost in it. And so bipedal ambulopathy is just a medicalized term I made up just for this example. And when you translate it from medical language, it just means difficulty walking on 2 feet. And there are many, many reasons someone could have difficulty walking. You could have arthritis, you could be paralyzed from a stroke, you could have a lung disease making it difficult for you to walk and you get winded really easily. You could have really heavy legs from leg swelling, or it could just be a really bad bunion. All of those things could lead you to have difficulty walking because we're just looking at the symptom or some very basic measure. And so the point is, just giving something a name doesn't always mean it's a complete diagnosis. Sometimes it's just the start. And, looking at this example, you probably agree that we can't just say that knee replacement surgery might help people with BPA, because, you know, you have to really focus in on the subpopulation of the people who have knee arthritis. And that would be the only time it would make sense. In other words, if you're paralyzed and you can't walk because of your leg is paralyzed, knee replacement surgery won't have any benefit for you. And this will all, make sense when I'm talking later about gastroparesis and some of the different treatments. But just keep in mind this sort of language issue. So what is gastroparesis? So it's a two-part word. Gastro means stomach. So anytime you hear the word gastro, it means stomach, and paresis means partial paralysis, or weakness. So really, the term we made up here just means stomach weakness. That's the diagnosis. That's the name of the condition. It's not, a very complicated concept here. But the diagnosis, when we think about this, there's three main things we're looking for. The first thing is that you have symptoms that are consistent with gastroparesis, and that could be early satiety, meaning you get full really early, more than you should get full from. Another common symptom is nausea and vomiting, and then also pain, which is not universal, but oftentimes it can be present. We also are looking for the absence of other causes, and the thing we're mainly focused on is like a mechanical obstruction, but what that means is like a physical blockage. And we're thinking, most worried about things like cancer, but of course it could be scar tissue, really severe inflammation, a foreign body blocking the way that can cause this sort of symptoms. And then lastly, we need to have objective evidence that the stomach is emptying in a delayed way, like too slowly. And so there are tests that we can do to try to measure that. Those tests are imperfect, but we have some to work with. In terms of the real estate we're working with here, the anatomy, I'll point out, I think you can see my mouse here. This is the stomach. It's this sort of like bean-shaped organ. So basically food goes through your mouth, down your esophagus, which is the food tube, and into the stomach, and then works its way through the small intestine, which is like this bowl of spaghetti in the middle of your abdomen, and then through the colon, and then into the toilet, basically. The closer look at the stomach, there's the esophagus leading into the stomach, and there's different compartments within the stomach that have different functions. I'll get into that in a moment. But just keep in mind, there's this pouch area called the fundus, and then there's this narrowing that kind of comes to a point called the antrum, and the antrum goes through a channel called the pylorus, and then it goes into the intestine. And I'm not going to go through this Rube Goldberg diagram, don't worry. But the point is that, I showed you the stomach's anatomy in relationship to the other organs of the GI tract, like the esophagus and intestine. But I also wanted to really highlight the point that the stomach is like totally wired to the central nervous system and to the sympathetic nervous system, etc. And so you can't really talk about the stomach in isolation because it has multiple connections to the nervous system. And so you can imagine a lot of things can go wrong, especially if you have like a neurodegenerative disorder. So in terms of what does the stomach normally do? And then just in terms of the motor functions, and motor just means like movement, like muscle related movement functions of the stomach. The first thing is, if you're thinking about, okay, you're going to eat a meal, the first thing your stomach has to do is it has to accommodate the food, meaning it has to relax and expand and make space in order to receive that food. Because when you're fasting, your stomach's pretty small, but you can imagine, some people, they can eat a lot, and that has to go somewhere. And the stomach is able to really relax and take in all that food. And during this time, the stomach is also helping to digest the food by releasing enzymes that help break down proteins and carbs, etc. But there's also a lot of mechanical digestion that's happening. And there's a word called trituration. And that's just a fancy word for grinding. And so basically, the food is being squeezed and pushed against the walls of the stomach until it goes from big pieces to smaller pieces. And then lastly, when the food particles are small enough, the stomach then pushes the food through the pyloric channel into the intestine for it to be further digested and absorbed in the small intestine. So this is I'm going to go over that again. There was a lot of words I just said, but essentially, if you look at the different functions of the stomach, so let's say you eat your food, and this part called the fundus relaxes. Well, it's mostly responsible for the accommodation of the incoming food. And then in the body or the corpus of the stomach, you get a lot of mixing, but then really in the antrum, where it comes down to this sort of point, that's where things get ground up, triturated. And it's like pushing against the closed door, breaking up the pieces, etc. over time. And then eventually the channel is able to pass through, like the small particles are able to pass the channel into the intestine. So you can imagine that at any part of this, process of taking in food, one step can go wrong and you can have symptoms. And that's the story with gastroparesis. Gastroparesis can be any one of these things goes wrong and you can have those symptoms of early satiety, getting full soon, or nausea or belly pain. In some patients, it's all of the above, but any one of these things can go wrong and you'll have problems. So essentially, if you're not able to accommodate food, like your stomach doesn't relax and expand, then you're going to get full immediately upon eating because there's nowhere for the food to go and you don't want to eat it. If the food isn't getting mixed and moved in the body of the stomach, then it's just going to sit in your stomach and not make progress. And if you have spasm or a contracture of the channel called the pylorus, then food's going to have difficulty getting out of the stomach and into the intestine. And so there's many ways to skin a cat, essentially. And so when we say gastroparesis, I think of this like made up disease called bipedal ambulopathy that I made up earlier. This is just a word, but there's many ways to get these symptoms. And at the microscopic and cell level, we're still not sure exactly what causes gastroparesis. There's a lot of research on this, and some researchers, more and more researchers, are pointing to a cell type called interstitial cells of Cajal, or ICCs. These are like pacemaker cells. Much like the heart, there's an electrical network within the stomach, and it has these regular rhythms of electrical activity. But if these cells are affected, then you lose that pacemaking ability. But other cell types can be the neurons or the nerve cells within the stomach itself can be affected, or it can be due to immune type cells called macrophages, or even scarring of the muscle tissue itself. And then outside of the stomach, the nerves that I mentioned earlier that connect to the stomach can be damaged. And those can be damaged, for example, during a surgery, like by accident. If you had a surgery by your esophagus or stomach, and that can cause gastroparesis-like symptoms. Or, this is more theoretical. If you have a disease process like Parkinson's, that can affect like the vagus nerve coming to the stomach, potentially causing gastroparesis-like symptoms. So in terms of diagnosis, so I mentioned the three things we look for are the symptoms, making sure you don't have something else going on, and then objective studies of gastric emptying. And so I would say, universally, I would recommend patients with these symptoms, be evaluated with an endoscopy, also known as an EGD, which is esophagogastric duodenoscopy. Easier to say EGD. So you can't really diagnose gastroparesis with a scope, but the main point is to make sure you don't have something else that mimics gastroparesis, because God forbid you have a cancer that's blocking food from emptying your stomach, and that's why you have symptoms. You should catch that sooner than later, and not just assume anything. And so this is, if you haven't heard of this before, it's kind of similar to a colonoscopy. It's a smaller scope. You go through the mouth instead, and it's a camera that you can look through and look at the stomach directly. So we're looking for things, cancer, ulcers, inflammation, etc. Now this is plus or minus, but it's reasonable for, if you tell your doctor about this, that they might get some sort of imaging study, like a radiology study. This could be like a CT scan of some kind, or special types of x-rays, like fluoroscopic studies, where they have you drink an oral contrast. And this is just an example of what that might look like. And this would be here, the stomach, and this would be the small intestine. I think you might start seeing some of the colon right here. And this can give you an idea, again, if there's something compressing on the stomach, if there's issues with strictures or narrowing of the intestine, et cetera, that can mimic gastroparesis. Maybe not necessary, but a reasonable thing to consider. Now, in terms of, actually determining if you have delayed gastric emptying because of gastroparesis, the main workhorse for this is something called gastric emptying scintigraphy, often commonly referred to as gastric emptying study. And if you've had this before, it's the egg salad sandwich test. They give you an egg salad sandwich. There's a tracer in there so that when you eat it, and they do special imaging studies, they can see that tracer in your stomach, and they can measure how long over time it takes to get out of your stomach. And this is all sort of done with computer assistance, etc. But the emptying should be assessed over a 4-hour period. Some places try to do things more quickly, like maybe 90 minutes, maybe 2 hours. But really, to be more sensitive and specific, should be done over a longer period of time. And abnormal is you have greater than 10% retained at 4 hours. There's other types of ways of measuring gastric emptying. And that's another one is with something called a smart pill is the brand name. And it's a capsule that you study. It's like a pill can. Not a can, a pill that has a bunch of sensors in it. And it can let us know how long is the pill in your stomach, how long is the pill in your intestine, and how long it is in your colon. Some people would argue it's not as accurate as a gastric emptying study, but it does provide a lot of other information related to the intestine and colon. So that can be helpful. We can talk about some of these issues in Parkinson's with this type of study. Now, in terms of treatment, again, like remembering that most patients with gastroparesis don't have Parkinson's. The first thing we often say is, eat small, frequent meals. That's the first line of therapy. And it's, avoid fatty foods, avoid red meats, raw veggies, fibrous foods, because those are harder for a weak stomach to digest and to pass through. And so, as you might be guessing, this is not great advice if you have Parkinson's and you're already having to time your levodopa with your meals. So this is not very practical and not something I usually lean on too heavily, because by the time someone sees me, they're already having issues with poor absorption of levodopa, their weight loss, etc. So I'm not trying to tell them to eat small meals. I'm trying to get them to eat more. And then there's medications. We'll get into that in detail, and then more invasive procedures and surgeries. We'll talk about that as well. So medications. So there's a lot of nausea medications, etc. But in terms of like directly treating gastroparesis, the name of the game is trying to speed up the emptying of the stomach. And so technically, there's only one FDA-approved medication for gastroparesis, and it's unfortunately metoclopramide, which is Reglan. And first of all, even outside of Parkinson's, I don't really like this medication because there's a risk of permanent neurological side effects called tardive dyskinesia. And it's most commonly associated with long-term use and higher doses. But gastroparesis for most people is like chronic condition. It's not going to go away in most patients. So, I don't like to use this medication because of those risks alone. But in Parkinson's disease, there's also a risk of Parkinsonian-like symptoms. And so it's really should not be used in patients who have Parkinson's disease at all. So that's off the table for all of you on this call, most likely. There's another medication called domperidone. And I haven't prescribed this drug in years because it's associated with significant cardiac side effects, increased risk of death. And it's, effectively, it's not available in this country unless you write per patient to the FDA to get approval for that patient to use this medication. And so, it's not just about being inconvenient, but also it's got a lot of side effects, and that's why it's inconvenient. They want to restrict its use. And so I try to avoid this one. Sometimes I've inherited patients who are already on it, and I usually wean them off of that and do something else. Erythromycin is an old school medication. It can increase gastric emptying, but it has a lot of side effects, specifically nausea and vomiting. And if you use it on a daily basis, you kind of grow a tolerance to it essentially, and the effect wears off. And so it's not something you can use on a daily basis. It's maybe good if you get hospitalized and need something once or twice to sort of get you out of a hump. There's a really old school medication called prostaglandin. It can increase motility, but it has a lot of side effects because it's not at all specific to the gut, and it has effects throughout the body. So I don't often use this one either. And many of these side effects are problems that many Parkinson's patients have at baseline. And so it might just make things way worse, like salivation, muscle twitching, cramping, nausea, etc. So I think the better option, which is gaining traction, is a medication called prucalopride. Brand name is Motegrity. It's FDA approved technically for constipation, and it works by increasing motility in the colon, but it also appears to increase motility throughout the entire GI tract. So it can, it's been shown to have benefits in gastroparesis in general, but also specifically in Parkinson's patients with gastroparesis. It doesn't interact with typical Parkinson's meds. I haven't encountered a patient whose med list had any issues with prucalopride. Maybe that'll change one day, but so far it's really safe and it's really well tolerated. But there is an FDA warning about possible suicidal ideation and depression. And that sounds super scary, but I can tell you I haven't really encountered a Parkinson's patient, at least, who has had a compelling, a case of this. If anything, most of my patients, their mood improves and, their depression goes away because now they feel better and they can eat and they're not constipated, etc. So I always warn my patients about this. And if you have those thoughts, stop the medicine. But I don't think it's very common, if at all, if it's even real. Another issue is that the drug is very expensive and it's not generic. So it's often a bunch of battling with the insurance company to get them to cover it. There are some workarounds. We can always talk about that later, but this is always an issue, and I wish it wasn't so difficult. I even looked at like cost plus, and it's not on there yet. So we'll just wait. Hopefully that'll happen one day. So in terms of the surgery and physical interventions, so what we're talking about are more invasive things. So Botox injection, it's not so much that invasive, but you can inject Botox into the first, let me take a step back. So of all these interventions that we're talking about that involve surgery or something invasive, virtually all of them focus on just this area of the stomach, like at the pylorus. And so as I mentioned earlier, there's many ways to get gastroparesis symptoms. But all of these interventions really focus on this type of gastroparesis. So going back to my first thing when I was talking about knee replacement surgery and difficulty walking, if you don't have knee arthritis, knee replacement's not going to help you. So that's what I really wanted to hammer home here. These interventions are for people who have this type of gastroparesis, really. But some of them are surgeries where they actually will cut you open and go do the intervention that way. And some of them are through an endoscope, like the EGD, and they can do things through the scope without cutting your skin to get to the area. Botox injections, we can actually, with the endoscope, thread a needle through and inject Botox into these muscles here. The idea being it'll sort of weaken or paralyze the muscles that are spasming and allow fluid to more easily pass through. Excuse me. The surgical pyloroplasties, that's more when they open you up and they cut the muscles in order to open up that pylorus. A balloon dilation, you can pass a balloon into the pylorus and inflate it and stretch open the pylorus. And the theory is that at least temporarily, this will open things up. And then G-POEM, it's basically like a surgical pyloroplasty in a way, except they can cut the muscles of the pylorus through an endoscope. And we can get, if you have more questions about that, we can get into the nitty-gritty about that. But essentially the idea is either paralyzing or cutting muscle or stretching it out. And it's just the pylorus. It's not, these interventions don't fix these problems. They don't make the stomach move faster. So a couple of words about Botox. So it's generally safe, it's pretty low risk. It's temporary, and that's a good and bad thing. And it wears off after about 6 months. So, 6 months is not a lot of time, and gastroparesis, especially with Parkinson's, is going to be chronic. So that the problem is that if you get repeat injections, number one, you get a decreased response each time because your immune system is starting to react to the Botox as a foreign intruder and will neutralize it faster. Number two, the more injections you do, the more scarring you get at the injection sites. And this is mainly an issue because it will complicate doing surgery in the future if you are being considered to get a G-colon or a surgical pyloroplasty. And so really the people who do those procedures would, they would usually prefer that you do this maybe once, maybe twice to see if you get a benefit from Botox. And if you do, that indicates that your gastroparesis is likely due to the pylorus issue. And then you can be considered for this sort of intervention. If you're going down this route, because you don't want to close doors, and so if you're going to go down this route, you should probably get these sort of procedures done, like Botox, etc., at a center that specializes in GI motility, just so that you don't end up getting like 6 rounds of Botox and then you're not eligible for further interventions. So the role of those interventions that I talked about. Okay, I just want to hammer home. This is for like pylorus related issues like spasms where the food can't get out of the stomach because it's closed. And then the benefit of these invasive interventions is not very clear because to date there hasn't really been any randomized controlled trials. I believe there's a GPON trial that's ongoing and people are very optimistic about that. But at this time, we're working mostly on, open label trials, non-controlled trials, etc. And so you have to, take it for a grain of salt. Or it's still kind of experimental. And then these procedures aren't without risk. You can have something called dumping syndrome, and it's a funny name, but basically it's a problem when your stomach empties too quickly and goes straight from your stomach essentially to your intestine. It can cause all sorts of side effects like abdominal pain, nausea, diarrhea. Your heart beats too fast. You get lightheaded. All these other things. So it's not without risk. And then how do you know if you're a candidate for this? How do you know if you're the type of gastroparesis that would benefit from this? It's difficult. We don't have very good tests that are widely available to determine what subtype you have. And a lot of it, again, is experimental, very limited places where you can get these sort of tests done. And usually it's more of like trial and error. Like, do medications that speed up your stomach help? No. Okay, let's try Botox. Did the Botox in your pylorus make you feel better? Yes. Then maybe you're a candidate. Like, that's the sophistication right now that most of us are working with because that's all the test tools we have. But I wanted to say, this is just conjecture. This is my hunch, is that in Parkinson's disease, I suspect, based on just experience, that it's not so much due to the pylorus being closed off and spasming, etc. It's more related to slowed motility in the stomach and more likely to respond to medications. But that needs to be studied further. But again, if you have Parkinson's, I wouldn't necessarily hang my hat on these surgeries. There's other things to try. Now there's I'll just sort of briefly talk about this. There's something that's colloquially called gastric pacemakers. Because like cardiac pacemakers, I think many people just refer to this device as a gastric pacemaker. Technically, it should be called a gastric stimulator, where you have like electrical stimulation directly onto the stomach in that pacemaker region, in the fundus. And that's thought to theoretically increase the contractions and help normalize the motility of the stomach. However, there have been a lot of studies so far, maybe not a lot, but a handful of studies that have not shown benefit. And there's case reports and like single individual patients that have had magical turnarounds. But when you look at population level studies or like larger studies, there doesn't seem to be beneficial. And so in practice, we don't use these gastric stimulators that often for gastroparesis, except for like sort of last ditch effort. There's no other options and the patient's really suffering, et cetera. We got to do something. The patient's open to trying something that might not work. This is not something I have referred out very often, and not something I'm very keen to do. So in terms of gastroparesis, but specific issues in Parkinson's disease, I've kind of alluded to some of them. So it's not clear how common gastroparesis is in Parkinson's, and the studies I saw really ranged from 25 to 70%, which is a big spread. But I think even 25%, the low end, is a lot. That's like a quarter of Parkinson's patients have gastroparesis. That's a lot. The issue is that it depends on how the gastric emptying was measured. There's different tests. As I mentioned, there's like some of them are breath tests you can do, but that's not recommended in Parkinson's, because if you have slow motility in the small intestine or bacterial overgrowth, which is common in Parkinson's in the small intestine, that'll throw off the test or the breath test. And so I wouldn't recommend the breath test if you have Parkinson's. I would say either the gastric emptying study, the egg salad sandwich test, or the smart pill would be better options. Speaking of the smart pill, so you might have seen that picture earlier, and this pill, if you can think of like a Centrum multivitamin, it's slightly larger than that. So it's a pretty big pill. And so if you have Parkinson's and it's associated with difficulty swallowing, you might not be able to swallow the pill, and so it won't be a test you could do. Also, if you have a deep brain stimulator in Parkinson's, I've avoided it in patients with deep brain stimulators. So I haven't gotten a clear answer if it's safe or not in those patients. So I contacted the manufacturer, and they wouldn't comment one way or the other because they hadn't directly studied that question. And I had discussed it with some of my neurosurgery colleagues who put in the deep brain stimulator, and they said it would probably be safe. But worst case scenario, you could just turn off the DBS. But in my mind, if there's alternatives, I'll just avoid that because the DBS is probably doing some good. Now, I mentioned the prucalopride or motegrity. There have been small studies, specifically in Parkinson's disease patients, that it is effective in gastroparesis. And that's, it's hard to find studies sometimes for this specific subpopulation of gastroparesis or an GI issue in Parkinson's. But this is, reassuring. And it also jives well with my experience. I mentioned that, that small frequent meals is an issue in Parkinson's, because if you're trying to time, you can't have, you can't eat for an hour after you take your pills, or an hour after you can't take a pill. If you're eating every 6 hours, when are you going to take your medication? Or every 3 hours, I should say, when do you take your medication? It would be impossible. And then I just wanted to underscore no Reglan. Avoid that. Sometimes I recommend to Parkinson's patients to list that as an allergy, because if you're in the emergency room or hospitalized for something unrelated, it might just end up on your ordered medication list on an as-needed basis, and not everybody is familiar with this contraindication. So just something to keep in mind. So some pearls of wisdom or experiences I've had with gastroparesis in the Parkinson's patient. So what I've noticed is that most of the patients with PD who come in with gastroparesis, their main symptom is getting full early and weight loss. And I noticed that pain and nausea are less predominant. And I'm not saying that they're not there, but like the first thing that they will note is the weight loss and the early satiety. And that's just a contrast to the non-Parkinson's patients who have gastroparesis. Like weight, most of these, a third of these patients are actually overweight. Weight loss is less common. And really what you hear mostly, like the biggest complaint is pain and nausea. And so it's different in Parkinson's. I have a theory also that gastroparesis may cause reduced effectiveness of levodopa type medications. So as I mentioned earlier, as you're probably aware, you have to time your meds with food, you have to avoid high protein around the time of taking your meds, etc. And the whole idea of not eating is that you're giving your stomach time to get to empty so that when you take your medication, it's on an empty stomach. But if you have gastroparesis, it's very possible that your stomach is never empty. Even if you haven't eaten for hours, you might have retained food in your stomach. I see this all the time where I do like an endoscopy and that someone hasn't eaten since the night before and there's still stuff in their stomach. It's kind of crazy, but it's true. So if you have gastroparesis and you can't get to empty in your stomach and you're taking levodopa, there's always going to be that competition for absorption with protein. And so this can, I've seen this a lot where patients will say they've had to increase their dose of levodopa over, months. And then now it's just not working as well. And then it turns out they have gastroparesis that's been brewing during this time. And this is anecdotal. Again, this is just based on my experience. And it's related to the prior, is that if you end up getting treatment for gastroparesis, you have to watch out that, that correcting this gastric emptying problem might lead you to absorb your levodopa well. And this, and you have to remember, when I'm meeting these patients, they've had increasing doses of levodopa to try to compensate for this poor absorption. If you suddenly fix the gastric emptying problem, you might technically overdose on your levodopa and get dyskinesias and stuff. I've had a couple of patients where we've had to reduce their levodopa doses because they were having bad side effects. So that's something to keep in mind. Again, this is something just on experience. No one's really published on this before. Now, especially in the past, we used to blame, the medical community used to blame the medications for all the GI maladies of Parkinson's. And I think that was unfairly so. I think, looking at the studies that looked at this, it's not really clear if levodopa actually causes delayed gastric emptying or not. The data are conflicting. There's different studies that say different things. And also in my mind, I think even if it did cause delayed gastric emptying, even if levodopa was the culprit, what are you going to do about it? You can't stop the levodopa. It's too important of a medication. You have to just work around it and figure things out. And then also a super important point is that you might have gastroparesis, but most likely you have constipation too, if you have Parkinson's, because it's not usually just localized to just one part of the GI tract. And constipation in and of itself can contribute to delayed gastric emptying. So it's really important to also successfully treat the constipation. And I stress successfully treat. That doesn't mean you take some stool softeners that don't really work. You did it, you've no longer constipated, and that's the goal. And then many patients will note that their gastroparesis symptoms also improve. And so, I actually recently started a telehealth clinic just for Parkinson's patients with GI issues. I'm doing it just once per week. I really enjoy working, with you all. I think it's a very, important problem, and it's under-recognized. It's not enough people focus on this problem. And it's also, just personally, it's interesting to me too. I think there's a lot of, exploration that can happen here, and you can do a lot of good. I currently do it all telehealth, and it's on a service called Rocket Doctor. It's all HIPAA compliant. You don't have to download any apps or programs or anything like that. You can just run it straight on the web browser. So it's super convenient. It should be covered by Medicare and most insurance plans. And to make an appointment, you can yourself just email this address, contact@pdgi.health, and we can set you up with an appointment. There's the address again at the bottom, the email address, but I wanted to leave a lot of time for questions. So there's about 15 minutes for questions or comments or what have you. But yeah, thanks so much.
Thank you so much. It looks like we've got some questions in the chat. Would you like me to read them out?
Sure.
First one from Laura says, I'm concerned about sedation for procedures like EGD. As a patient with Parkinson's and an older adult, it is risky. I have 2 friends who came out of orthosurgery confused and it never resolved.
Yeah, I think, depending on the level of sedation, like the duration of the sedation, there is a concern that it can precipitate like, delirium, etc. And like sometimes I've heard from my neurology colleagues that after a prolonged sedation, sometimes patients never quite make it back to their baseline. And so we do try to avoid that. I think with endoscopy, these procedures are literally like 5 minutes usually. And, and it can be pretty, you don't have to necessarily knock someone out completely. It can just be something called like conscious sedation, for example. And so I think the risks of long-term consequences from the sedation are lower with endoscopy. But that's a valid concern.
Thank you. Question from Jen. Is magnesium oxide a medication that can be used for constipation? My primary care recommended this medication by starting 200 milligrams and increasing up to 600 milligrams as needed.
Yeah, so, I think, I have mixed feelings about magnesium-based laxatives. I think they've been around for a long time. There's a lot of different types of formulations, etc. And what's funny is that like in the GI world, like in fellowship training and all that, we don't really use them very often, but just at home, lots of people use them. Over the counter, it's super common, and it seems to be pretty effective. I think, I used to have a very hard line against them, and the main concern is that, if you have, problems with your kidneys, for example, you could have a dangerous buildup of magnesium in your body that could even be deadly. And it's difficult to prevent that from happening if you're taking this medication on a regular basis. And so usually I recommend, some other medication for constipation, whether it be Miralax or Picalipide or something else, and then, or suppositories, etc. But then using magnesium-based laxatives on an as-needed basis if you need it every so often. But, using it every day, I get a little nervous, especially, considering that, Parkinson's is usually later in life, and then people's, renal kidney function can decrease as they age. So, I just don't want to have any serious side effects when there's alternatives.
Question, how familiar do you think most GI specialists are with Parkinson's-related gastroparesis or other GI issues? I think she means in the person with Parkinson's.
Yeah. So I that's a good question. I think I'll tell you, like I got interested in Parkinson's disease in the GI tract because of the research I was doing during my PhD, for example. And I never learned about the issue of drug absorption on an empty stomach and timing the meds with meals and stuff until I was like deep into starting this clinic. And I don't think most GI doctors know about it. I don't even think most dietitians know about it. I learned about it from my patients, and then you speak with a neurologist, and they're all very familiar with them too. But I think that's like a very crucial point. Is the drug absorption and gastric emptying for levodopa, and that's something that probably most GIs don't know about. I think it's a matter of educating people, and I think if you have a gastroenterologist, make sure they know about that. And it's easy enough to learn, but it's not. Don't assume people know them. It can really affect what the recommendations and treatments are.
That's a really good tip. It's really important that we always are advocating for ourselves at every medical appointment. Question from Jen, is there any relationship with heartburn or GERD symptoms?
So I think so, yes. So I might want to go back a little bit. So let's go to a picture of the stomach. Okay, so heartburn or GERD, which is gastro stomach esophageal reflux disease. So it's like all these acronyms and stuff. But that's just when contents of the stomach go back up into the esophagus, into the food tube. And that, the contents are acidic because the stomach makes a lot of acid. That causes burning and can cause other, problems like, inflammation, ulcers, like scarring, strictures, etc. So it can be a real problem. So, you can get GERD or heartburn and not have gastroparesis. That's most commonly, you just have GERD and nothing else, right? But if you have gastroparesis and your stomach is just overfilled and it's not functioning well and not pushing things down into the intestine, it just increases the probability that you're going to get reflux up into the esophagus. So oftentimes, fixing the gastroparesis can help with the GERD. But don't just assume you have gastroparesis if you have GERD. You'd have to confirm that diagnosis. But the two often go hand in hand.
Thank you. What do you recommend regarding pre and probiotics?
Yeah. So I get this question a lot. And, I think I would say my usual advice is to just try to obtain probiotics through your normal diet, through naturally probiotic foods, like certain types of yogurts, kefir, sauerkraut, etc. Because the data is not that clear about probiotics. I think there's a lot of animal studies that are very exciting, but until we get randomized controlled trials in humans, I can't make a formal recommendation to do those things. And then what complicates things further is that most probiotics, the types that most people use, are bought over the counter as a nutritional supplement. And most nutritional supplements are not FDA regulated. And so I don't even know what's inside of those pills. It could be, what they say is in there. It could be some other bacteria. It might not be pure. It might be completely empty. It might just be a sugar pill. I have no way of telling. And they can be kind of expensive too. It's a huge industry. And so I don't usually encourage it. If someone does it on their own and they say it helps, I don't force them to stop or anything. But at this time, there's not enough, strong evidence to support using it.
Thank you. Another question. I've seen research that indicates women with Parkinson's suffer more often with gastroparesis. Have you noticed this or any other gender or ethnicity trends?
So gastroparesis in general, not just Parkinson's, but in all cases, is more common in women, and it's not clear why. In terms of the specific subpopulation of women with Parkinson's, I actually haven't seen much data about its prevalence in women versus men. In my experience, it seems pretty even. But again, it's still pretty early.
Thank you. Could inflammation or an immune response due to food-related allergies or intolerances lead to gastroparesis? I ask because when I eat some foods, for example, soy, tomato, and a few others, my levodopa meds virtually stop working for the following half day.
That's interesting. I don't know of gastroparesis being sort of episodic like that. Usually it's a chronic issue that's just always there. If you have some sort of food intolerance, it might not be causing gastroparesis per se, but some other symptoms that are similar to gastroparesis. And for unclear reasons, it sounds like you're having absorption issues with your levodopa with certain types of food. And it might be that the particular proteins in those foods are better at competing for absorption than levodopa, at least in your system. But that's just a conjecture. But that's interesting.
Thank you. This is a good question that I don't think we've covered. Do you think neurologists should check for GI issues before automatically increasing levodopa dosages? I don't know if you can answer this one, but
yeah.
Thank you.
Well, yeah, I always defer to neurologists. Like they're the masters of their domain, and I learn a lot from them. But I would say what would be reasonable is if you had a patient who was doing well on a dose, but then needed a slightly higher dose, and then over time more and more and more and more, then to consider what's going on. And it could be an issue with absorption related to gastroparesis. And that's, I wouldn't say that they necessarily should be doing all these tests because it's a little outside of their domain, but maybe refer them to someone who, who has experience with motility testing of the stomach. But it might just happen that you just the natural history of the disease, you require higher doses, but it's something to consider as an alternative.
Is there a standard definition of constipation?
Yeah, so there are some technical definitions of constipation, and there's even subgroups of constipation too. It's like the Rome criteria, etc. And those are mostly useful for like research purposes to standardize things. But when I'm in clinic, usually I just talk to the patient, try to get an understanding of what their symptoms are, and we don't go through this very like technical specific definition. I think that's what most clinical practice is like. Because like the problem is, especially in Parkinson's, if you look at a previous talk I gave for PCLA, there's like many ways to get constipated in Parkinson's. And so some patients will have many frequent small bowel movements, but they're super constipated. So it's not just about bowel movement frequency. Or there's some patients who will have a bowel movement every 2 or 3 days and they feel fine. And so are they really constipated? And so, in practice, I would say there isn't a very firm definition. It's about symptoms and the overall picture too.
Thank you. And we have a related question. Is it okay to take Miralax daily?
Absolutely. And so I often say like it's called Miralax because it's a miracle laxative, right? And it's like you can't really overdose on this medication. It's not really absorbed into your blood. You might take too much where you get diarrhea, but effectively you can take it every day. You can take it twice a day, every day, or like two capsules at once. The main goal is that you would need to, mix it with enough water for it to work effectively. And just to, a quick recap of how it works is like, I like to think of Miralax as like little sponges, and it draws water, sucks water into the inside of the intestine and the colon. And so it just makes things wetter and helps flush things out. That being said, if you have really severe constipation, it might not be enough and you might need something additional to Miralax. But for most patients with constipation, Miralax can be really helpful.
Great, thank you. I don't think we've touched on this. Does extended time use of omeprazole contribute to any of this? I get full very easily, have bloating, eat a healthy diet, have no weight loss, but it can fluctuate pounds per day.
So omeprazole, I think it's a proton pump inhibitor. There's like a couple of drugs in this category, PPI. So PPIs have been, a lot of researchers have tried to pin some sort of bad outcome related to PPI use because they're so ubiquitous and people use them chronically, et cetera. And like, there have been studies looking at associations with multiple different outcomes. I won't even go through all of them, like osteoporosis, fractures, kidney disease, this, that, the other thing, et cetera. To date, there's been some associations, but when they've looked at them more robust studies to really test that association, they've fallen apart. And so there hasn't really been strong associations for any significant side effects with PPIs. And the main thing is, if you need to take the PPI, you should take it, like the omeprazole. But if you don't need it, we forget sometimes to discontinue medications. And so if you don't need it, then you should stop taking it. But that's something you should, of course, clear with the doctor who prescribed it to you before stopping it. But yeah, there have always been, you can find so many little studies that point to a possible association or link with dementia, with gastroparesis, et cetera. But it hasn't really panned out. They really dug deep.
Thank you. This is something I don't think I've ever heard of before. The question is, I have Parkinson's for 22 years. I'm age 65. I sometimes wake in the middle of the night gasping for air. I raise myself quickly and often have a foul taste in my mouth. Is this part of gastroparesis?
So that's a serious symptom. You should get that checked out for sure. But from a GI perspective, one possible explanation could be reflux. And as I mentioned before, if you have gastroparesis, it can contribute or worsen reflux. And so if you're having reflux that's going all the way up your chest and then into your upper throat and then down into your lungs, you're aspirating, meaning it's going into your lungs. And that can cause maybe some of those symptoms. And so that is, something I would take very seriously and get that checked out right away. Because, that's, you would need to, like omeprazole is not going to fix that. Omeprazole is, for reflux, it helps by deacidifying the acid in your stomach and preventing like the inflammation. But even if it's deacidified, if you have reflux going all the way up into your lungs, it's still going to cause problems, like, maybe even long-term lung damage. And so that's something you should get checked out right away. Of course, look for other causes like heart issues or lung issues that could be contributing. But from a GI perspective, it could be reflux.
Thank you very much for attending Let's Talk Parkinson's. We hope you'll join us later this month for a virtual Let's Talk Parkinson's event on the genetics of Parkinson's. You'll receive a link to register for this event by email. Today's event was brought to you by our Let's Talk Parkinson's sponsors, Abbott, AbbVie, Boston Scientific, and Medtronic. And by you. By donating to PCLA, you can join us in our mission to improve the lives of the families in our community who are living with Parkinson's. PCLA is a nonprofit, and all donations are tax deductible. If you enjoyed today's program, please consider donating at PCLA.org to help us continue our work and to continue to provide programs like this for free. As always, you can reach us with questions at info@pcla.org or by phone at 310-880-3143. It's 310-880-3143. Thanks, everyone.